Welcome everybody to this meeting in public of the Worcester Acute Hospital NHS Trust Board. My name is David Nicholson, I'm the chair. This is an important meeting for the board. There's a lot of really significant issues that we need to talk about this morning. And can I particularly welcome Dawn Forbes, who's going to help us with some conversation about a story relating to a family. One of the things that I would say is that as far as the board is concerned, it's really important to start our deliberations with a conversation about the reality of the services that we provide, either good or bad, hearing from patients, staff and people from the local community about what their experiences of our services are. Partly because it's important that we understand and know and celebrate some successes, but also that we know when things are not going right. And it does have the benefit of grounding our conversations for the rest of the board meeting in the reality of people's experiences. So can I pass it over to Paula, I think, who's going to introduce this.
Many thanks, Chair. And yes, absolutely welcome to Dawn. I'm not going to say very much because Dawn has done all this amazing work and has gone above and beyond. So I do want to thank her for this. So what the running order now will be that Dawn will say a few words. She'll then share a film. And then we'll, once that's wrapped up, hopefully bail on and just to welcome the family if they are watching via live stream. So if you are, thank you very much for joining. So without further ado, I'll hand over to Dawn and thank her again. Thank you, Dawn.
Thank you, Paula. So hi everybody. So yes, my name's Dawn Forbes. I'm the Children and Young People Oncology Nurse Specialist based here at Worcestershire Royal Hospital. So my actual job is to care for the children with cancer here. I have worked at Birmingham Children's Hospital prior to working here, and my job there was as a nurse educator. So I am familiar with the whole haematology and oncology team over at Birmingham Children's Hospital. So last October, I had a request from one of my colleagues at Birmingham Children's Hospital from the haemophilia department, asking if I could help a family in dire need. The mum will be on a video shortly, so she will share her experience with you, but she has two boys who have a haemophilia disorder who need potentially life-saving treatment to be administered 3 times a week. Mum was the lady in the carer in the family that was responsible for accessing both of her boys' veins to administer this treatment, so it's quite a skill that she needs. At that time, Dad wasn't trained to do this procedure. The family found themselves in quite a bit of a crisis situation in the fact that Mum was quite poorly and needed hospital treatment here at Worcestershire Royal Hospital. So arrangements had been made for the father to be trained at Birmingham Children's Hospital to administer these medications to both boys. However, unfortunately, he actually suffered a car accident, so he was really quite poorly as well. Probably didn't have a car, I'm not sure, but obviously I felt that you know, the pressure on this family at this time was quite immense. So Birmingham Children's contacted me to ask me if I could facilitate the training to the dad here in Children's Clinic at Worcester Royal Hospital. So immediately, I think as we all do in healthcare, when we're faced with a situation with any patient, we always try to put ourselves in their shoes. And I've always done that throughout my career. I've always tried to imagine what it's like for that person, that patient, that family going through that situation. So immediately I just thought about the pressures that the mum was under, the worries that she had, that she was poorly herself, that the dad was unable to probably drive all the way to Birmingham Children's Hospital, the cost and the time associated with that, but more importantly as well, the time away from school that both boys would have missed by having that extensive travel and waiting times at Birmingham Children's Hospital. So So I just knew immediately that I had to help this family, even though they weren't technically my patients. I just felt that I had to help them. I just felt that there was no choice. And if it was me in their situation, I would want somebody to help me. So, and also working with colleagues as well. So I know that the team at Birmingham Children's, that they would help me out. And I think, you know, there's karma, you know, what goes around comes around. So I know that by helping this family, I know that Birmingham Children's will help me, and we work so well together with all of our patients. So for me, it was a given that I help this. Has made a short video, which I believe Anna is going to play now.
Hello, my name is Kulala. I am mom of two beautiful boys. My boys under care of Birmingham Children's Hospital. They have a special bleeding disorder which called Glanzmann thrombocytopenia. It's quite rare. Around 1,000 people has it in the world, so not so many people know about it. And when they injured, they have to have a platelet transfusion or novel 7, factor 7, and tranexamic acid. And that factor 7, they have to have it as a like every other day as a treatment. And last year, September, I had the operation which went wrong. I had a very bad complication with it, and my husband in that time, he got a very bad car accident. He got injured. He wasn't able to drive to Birmingham, and I was only one who trying to give induction to my boys. My husband that time, he wasn't trained, he didn't know anything about it, and he was just showing me to do it. He never done it himself. And if Dawn didn't offer us that she's gonna teach my husband, we have to go to Birmingham every other day, and that's quite a long way, and the boys would have to miss the school at least half a day, and it's not fair. They want to be with a friend and play with them, just enjoy the day without being in hospital every other day. And Dawn very kindly offer us to teach my husband and whatever time fit us as a family after school. And while I was in hospital, I was coming to see them as well while they were doing their training. And what she done for us as a family, it was massive. She has changed our life. Used to be, I felt I was under a lot of pressure because I was the only one who were giving boys their medication. But now I'm relieved. I could go wherever I want, whenever I want, because my husband can't do it as well. And she's done an amazing job. She managed to teach my husband in 4 weeks, which was unbelievable. And she told my husband, there's no rush. Call me when you need it, as many times you want, we can do it again. And if you struggle while I was in hospital, she kindly offered that she will do it herself. Just call her, make appointment, and she would have seen my boys and she would have given the injection. It might be simple thing, but she has changed our life. I really, really can't thank her enough. Thank you very much, Dawn.
And thank you.
Thank you.
So it was lovely for me to watch that video when you sent it, Anna, a couple of weeks ago. You know, we offered this service to them when we were actually very busy as an oncology team, but as I said before, I just couldn't turn them away in their time of need. And again, I just felt it was important to work the appointments for this family around their school time so that they missed even less time away from school. But I just have to say it was just an absolute joy to look after this family and the two boys. They're just such a delightful family. And I was glad to be able to help them out. I'm also very appreciative that Birmingham Children's had recognised us. I think for me the biggest thing and the most rewarding thing that has come out of this experience is that I didn't realise the actual knock-on impact it would have on the mum, because it's actually given her more freedom as well. So for me, it was just a pleasure to be able to do this for them.
Thanks, Dawn. That's marvellous, and the story is just really, it's just so heartwarming. But well done to you. Bailon, you're here now. Did you want to say a few words before we go to questions?
No, not really. I think Dawn's articulated things that, really well. I'm brimming with pride, as you well know. I have huge respect for Dawn. I'm so lucky that she's part of our team, and I think, the only thing I would say is this is probably just one of a number of occasions in which this fantastic lady has gone above and beyond for our patients, and I think the importance it highlights is how such a little thing can make such a big difference. There's no time in Dawn's day to do this, but because she made time, it makes such a huge difference to the lives of this family, and as she does to all of the families that we look after. So yeah, I don't think there's anything more to say on that front. Well done.
Thank you, Bailon.
Thanks, Bailon. That was fantastic. We should actually say award-winning Dawn Forbes, shouldn't we, when we talk about her? But a great.
And don't forget award-winning Bailon as well, please, Chair.
Yeah, all right. We're not talking about him at the moment. Oh, he has enough, search on us. Like, great. I mean, fantastic. And thanks, Dawn, for what you do. Are there any questions or comments that people want to make? Yes, Simon.
It's just a very good example of the NHS at its best. Those of us who are fortunate enough to serve in a non-exec capacity never cease to be amazed by services of people literally going the extra mile to help those who need the help, and in this case those who weren't even our own patients. But it is, as I say, just another wonderful example of what people who work in the NHS do on a day in, day out basis. This is perhaps an exceptional instance, but it is the sort of thing we see regularly when we talk to staff, and I just can't say thank you enough, Dawn, so thank you very much.
Anita.
Yeah, I mean, obviously echo Simon's comments. I mean, lovely story, well done, Dawn, and it warms the cockles of your heart to hear stories like that. So, really, really well done, and it was great that we put not even our patients, we put a family first, which is great. I guess the one question I have is what seemed to come across from your story was that it was your personal relationships with Birmingham women and children that was effectively the thing that allowed this to happen. And I guess that makes me wonder, are there any mechanisms, and I'm not just talking about paediatrics here, I'm talking more generally, but is when these great things happen, when we can help out partners, does it generally happen because of those personal relationships? Is there any formal way of monitoring or tracking situations? And this isn't really a question for you, Dawn, but maybe it's for Matthew. I don't know, but I don't know. It worries me in a way that if you hadn't had that relationship, we might not have known of this need. And I guess that says to me, is there any kind of official way, some list somewhere on the internet that says, that we've got this problem?
Interesting question, Anita. I think the key, Bailon probably will be able to help us out. I suppose my, off the top of my head, reflection is that we are in a kind of now quite a COVID period, really trying to refresh our strategic partnership relationships with some of our key tertiary centres, Birmingham Women's and Children's being one, University Hospitals Birmingham being another, so that we're clear on where there might be particular clinical pathways where there needs to be close relationships. My experience, and Bailan I'm sure will be is clearly much closer to this, that the communications into the Children's Hospital are pretty consistent daily and I think well organised. But I guess, Anita, it's an interesting question just to perhaps reflect on. Bailan, perhaps over to you.
So I think you'll find with a lot of the paediatric specialties, particularly when we're working, so our respiratory team, our oncology team, I did train a significant amount of training at Birmingham Children's Hospital and maintained those relationships throughout. And we work very much on a hub and spoke system. Part of the reason that we are not an accredited paediatric haemophilia centre, and we don't have the throughput to become that, but actually because of our close relationship, which is due for again, Dawn coming from the Children's Hospital and us being able to attract nurses who have worked there. We've got nurses in our paediatric respiratory service who've worked at the Children's Hospital and at big hospitals. You bring that expertise from the tertiary centres to provide local care for local people. And what we can't do is we don't have systems set up or and it probably wouldn't be right for us to have a haemophilia service, but it does enable us to come in, parachute in and help in these circumstances. Before this, actually, we were also giving the boys transfusions locally to help prevent them having to go up to Birmingham as well. When they're there, the only problem is I'm the only one from a medical point of view that has the expertise. Dawn is one of a limited number of nurses. But I think what is reassuring, what's good, is that since Dawn's arrival, we've actually had a significant number of nurses with tertiary experience from the oncology team come to Worcester on the back of knowing that they'll be working with Dawn, and knowing that actually they'll be able to continue their specialty interest here and treat those children, as well as take on the new challenge of managing some general paediatric patients as well. So it's part of the team. I've said Dawn's a bit of a force of nature, and she's well respected within her field, level. So it helps improve our reputation, and I think because we've done so many good things, actually they come to us for help quite a lot, which is really nice, actually, because it's nice to feel that we can help support our tertiary centre in delivering these services.
Thanks. I mean, I think that taking the broader point, there is no substitute for personal connections in all of this. No matter, and there is always a danger you bureaucratise the problem. I mean, in some places I've worked before, the first question Dawn would have asked, not Dawn, but their equivalent, would have been, how are we going to get paid for doing this? And that's not the way we operate here. We treat the patient, we look after the patient, then we work out all of that stuff afterwards. And that seems to me the right way round. The danger is of a bureaucracy that does it the other way, which kind of I don't want to, but I noticed in the note that I got, we have had a conversation about this before, but in the note that I got, it says that that the Wye Valley Trust has stopped being a shared care centre for paediatric haematology oncology since October 21, and that we've taken responsibility for that. Do you just want to tell us the story behind that?
Do you want me to do that, Dawn, or do you want to do it? Shall I do it, or do you want to do it? Just for people that don't know, paediatric oncology services within the West Midlands and throughout England are arranged on a hub and spoke system. So there are a set number of principal treatment centres around the country, and for the West Midlands, that's Birmingham Children's Hospital. And then units called POSCUs, which is the Paediatric Oncology Shared Care Units, of which Worcestershire Royal Hospital is one of them. So Stoke, Wolverhampton, Shrewsbury and Telford, Burton and Coventry, and New Cross are the other ones. Not all of the district general hospitals within the region are POSCUs. Wye Valley were also a POSCU, but they were unable to appoint a clinician who had the appropriate training to continue the service. And so when Simon Merrick retired, the families were faced with the choice of having to go up to Birmingham for their treatment. So we agreed that actually it seemed silly for most of them to drive past us on the M5 to get to Birmingham already receiving. So we, again, it was the right thing to do, and we did it, and we took it on within our current resource portfolio. It's been a challenge, hasn't it, Dawn? But it's the right thing for the families, and the families they were initially wary because, of course, they're upset that they can't go to their local hospital anymore. But actually, the feedback is they like coming to the clinic, they like the environment, it saves them a lot of time. And the one thing that we can do, which the principal treatment centres can't do, is personalise the care a little bit more. I'm looking at upload. We look at probably around about 20 new diagnoses per year, and a total cohort of about 60 patients when it comes to the oncology. So actually, we're a friendly face, we're the same people each time, and that's really important for these families because it gives them that. So yeah, we took on, it increased our sort of chemotherapy workload and acute workload by about 50%, but we just felt it was the right thing to do.
I think given some of the stories we've heard in the past, that's a great story about the hospital reaching out. I'll ask the question, David. I think I know the answer, but I'll ask the question anyway. Are we being paid for it?
Yes, we are. I think don't get me on block contracts and various other things. I'm not sure. We've asked for a meeting with Maria from the ICS to look at it, because as opposed to in the past where it was PBR, it's now block contract. I'm not sure whether that money is transferred across, but the activity is being recorded. Whether that comes out as an additional payment, I'm not 100% sure at the moment.
Thanks. We just need to make sure we do that. I mean, I know it's not the most important thing. The most important thing is getting the people treated. And great the way you worked with the other hospital and the children's to make sure the people were transferred safely and all that. It's great. Okay. Any other questions that people want to raise while we've got them here? No. How old are the boys, by the way? How old are the boys who are getting treated?
They're about 12 and 10 years of age, I think, Leland, is that right?
Yeah.
If you're watching, boys, mother and father, I hope you're doing well. As you can see, Bailon and Dawn are doing everything they can to help and support you through this. And thanks for raising the issue, and thanks for doing the daunting video. I know it is to us, but thanks very much for your cooperation in all of this. Thank you. Well, thanks, Dawn and Bailon. Thanks for everything that you do. Again, inspiring people that you are. Thank you very much.
Thank you.
Okay.
Thank you.
Let's now move on to the rest of the agenda. Have I got any apologies, Rebecca?
Yes, Chair. From Mr. Richard Eastrom.
Right, thanks very much. Are there any items of other business? The only thing that I would say is that given my understanding that some of the executives have got an important meeting with the region at 2 o'clock to consider the ongoing urgent care issues, can I suggest that we convene the private part of the meeting at 1 o'clock rather than 1:30? I know for those of you who've got a 5-course lunch set up or whatever you do these days, but I think it would help, because I think it's important that the executive are around for some of the important considerations in the private board meeting. Thank you for that. Okay. Declarations of interest, any related to the agenda today specifically? No? Okay. Minutes of the previous meeting, are they a reasonable reflection? They are. Good. Action log, Rebecca?
Thank you, Chair. A number of the actions have been closed as per the log. In respect of the open and still ongoing actions, there's updates being provided against each, and in the vast majority of cases, they're items that have already gone through like the subcommittee level of the Trust Board, and will be reporting up in due course. Thank you.
Okay, just an observation really on all of this. As far as I can see here, there are 2 items on the action log relating to the charter, behavioural or otherwise, and I'm sure this is not. I'm being worried for nothing at all, but I'm just slightly nervous that this is turning into some kind of industry rather than what it's supposed to be, which is a really kind of sharp thing that we can get on and do. I just make that observation just to make sure that people are kind of moving on it, because we need to get it to the board. We need to get it sorted out. This is not. I mean, we can have a conversation. Sorry, Tina wants to say something about this, I think.
Week before last, and we're focusing on the violence and aggression element of it first, with the civility and respect afterwards. And so it's a way of us trying to make progress against that charter, David. So I'll bring a further update to the next meeting, if that will be helpful.
Yeah, have we actually approved the charter?
Yes, we have.
Have we? Right.
Yes.
So this is about the implementation of it.
It is. Let's bring it to life. Yes.
Yeah. As I say, we don't need to make an industry of it. We need to get on with it. Okay, Simon. Thanks for that. You should bring it up then. Yeah, Simon.
Exactly that point I was going to raise, what happened in the People of Culture Committee. As has been said before, and particularly is said again and again at the BAME Staff Network, we need something that just works instantly, so that if something happens, a member of staff knows exactly what they can do, and that they'll be supported if they report something, so that we change the culture of the organisation where these things are ignored, generally, to actually being the other way around, where action is taken straight away. And it's the see it, say it, sort it type thing you hear on the London Underground. There needs to be a process as simple as that. It's taken us a long time. I know these things are not straightforward, but there'll be others around the country who've got best practice. We might look at those. So I would encourage everybody involved with this to actually make it happen, rather than this being a piece of paper. And I know the intention of everybody is that it will happen. The only question I got is, when are we having the LGBTQ plus to the board? I think that was an outstanding action as well. Do we have a date yet for that?
If I can come in on that, Simon, I'm doing a piece of work to look at all the networks, and we're going to get them scheduled in, and we'll book that in on a regular basis, so that committee's got an update. So that board has got an update across the entire networks across the trust. So we're just going to discuss how we do that as a whole, rather than looking at one network in particular, and we'll make sure all of them have got that opportunity.
Yeah, we just need to. I know that. That people want to do it right, and that's absolutely the case, but sometimes getting it 100% right takes longer than getting it 70%, right? That's all. So we just need to get on with it. Okay, that's fine. Thank you very much. Let's then move on to that's the action log. Let's move on to the to my report. Very brief. I undertook chair's action in relation to a contract. Is that acceptable to people? Yes, thank you very much. Let's move on to the Chief Executive's report.
Thank you, Chair, and good morning, everybody. Obviously, you have my report in front of you for this month, which I'll take as read. I think just reflecting on your comments, Chair, earlier in relation to operational pressures, I want to again reiterate the executive team position, certainly my position, that we continue to be really deeply troubled by the ongoing ambulance handover delays. We recognise that has a significant safety risk for our patients, but also the operation and safety issues experienced by the ambulance service, and obviously our staff under significant pressures in our emergency departments. And the focus, whilst of course is on elective recovery and our financial management, the topic that we talk about most as an executive team multiple times each week, each day, really is how we continue to get some of the new initiatives that we have in place working effectively to drive down ambulance handover delays, which we are seeing some signs of improvements, but that's against a backdrop particularly of walk-in attendances increasing by around 11%, particularly this week with the staffing challenges that our partners have had with minor injuries units, having a particular increase at the Alex site that's had a particularly challenged week. I'm sure Paul will talk later about the ongoing challenge to get the 29-bedded facility that was centrally funded to increase our bed capacity on the Worcester site, and has been hampered by unresolved water contamination problems, which we expect at the end of this month to be resolved. But it's worth noting for the board that not only do we expect that to address some of the offload delays, but it's also intended to create a clinically ready to proceed area alongside the ED, which we expect for the ambulance team to be able to use also for cohorting some of their patients, which we also think will improve the safety concerns that we know the ambulance team have. So I want, before going on to the items in the report, Chair, just to note that really being our complete laser sharp focus as a leadership team to try and get right with our partners across the health and care system locally. To just draw attention to the report, obviously the appointments to the Integrated Care Board we touched on last month. The nomination for the Acute Trust, but also noting there the other people that have been appointed, and the intent, I think, of Krishni, the chair, to make sure that each of the three provider trust chairs are in attendance at the meetings as well, which I fully wholeheartedly support to maintain that continuity. Draw attention to the Worcestershire Leaders meeting. This is a regular meeting that the County Council and District Council the leaders and chief executives has. I joined them for a meeting last month to just reflect on the progress that we're making in the health side, but also to really draw attention to the opportunities of us working more closely with the council, particularly at district level in the development of district and neighbourhood teams, from a health and care perspective, to really drive out the inequalities and the wider determinants of health, education, housing, employment, but also making sure that our strategy that will be articulated in our 3-year plan is properly aligned with the council's county council's emerging strategy. And also just to draw attention to our continuing work to drive the digital agenda for our patients, and the reference there to the continuing development of digitally enhanced, efficient ways of working. I think this is also important in the context of the national drive to increase the prevalence and the number of patients that are looked after at home within the community setting, within a virtual ward environment. And we're in close discussion with the Health and Care Trust, who'll be leading on that, to make sure that where it makes sense and where it's possible, our consultants and clinical teams are closely involved in supporting those patients to stay at home. The national view is that we'll have a significant impact, if we get it right, on reducing demand into emergency care. So I'll pause there, Chair. Happy to take any questions.
Thanks, Matthew. Any questions, comments? Simon.
Matthew, the non-execs on the ICB, is that the full complement now?
I think there's a view from Krishni Waring that it's a bit underpowered from a non-executive perspective, but of course there was quite a consideration of getting the balance between representatives, if you like, from the service, executives within the ICB, and provider and other representatives, GP representatives, and hence why the idea of two non-execs supporting Krishni's position was essentially what went into the Constitution. I suspect that will be being re-looked at. I don't know whether the fact that the 3 chairs now joining the meeting will perhaps help to supplement that, but I know that discussions are underway. Anita may be closer to that.
Yeah, it's just a point on governance. I should have followed this a little bit more closely, but is the ICB board following the dual board approach where the non-execs should balance out the executives, with a casting vote being the non-exec chair? No, I see David shaking his head.
So it's a tripartite board. It's got non-executives, it's got partner members, and it's got executives. And when it was designed in such a way as there was a balance between the 3. So in a sense, no 2 could outvote the other. That was the design of it. I think what's happened in practice, when you look at it and they try and sort it out, they simply haven't got enough non-executives to do the basic, chairing the various subcommittees and all the rest of it. So they are underpowered. So there is a group set up by Krishna, which is now, I think, decided to increase the number of non-executives to give it a bit more firepower and a bit more balance. In a sense, we concluded that the idea of a tripartite balance is outweighed by just simply needing enough non-executives to do the basic functions of the board. So I think you will see a number of other non-executive posts come out.
It's important that we have people who do come from an independent perspective. These are going to be some very difficult conversations and decisions that have to be taken, but
okay, any other points, questions? I think the whole issue of the urgent care position, I know we'll have a chance to talk about it a bit later, I guess. But I do think it would be really helpful for us to have a proper paper setting out the kind of numbers around ambulance handovers and all the rest of it over a time series. Because I think what I'm really worried about, I mean, obviously we're all worried about the current position, but where is this going to end is the issue that I'm thinking about, not least of all the coming autumn and winter. I can't see at the moment, I may be wrong, I can't see coming out from the centre any particular solutions to these problems. So we really do need creatively to kind of focus our attention on this and think about how we're going to manage through what is undoubtedly going to be a very, very difficult winter and summer, to be honest. But Matthew.
Yeah, thanks, Chair. And I think just going into a little bit more of the detail, I mean, we've as a leadership team, particularly taking into account our approach and way of thinking and change of way of thinking in relation to our implementation of our forward improvement system. We've challenged ourselves, and Paul and Christine will be challenging our clinical directors in a meeting very shortly, as to really whether we really understand what the data is telling us about our length of stay, our long length of stay numbers, which actually are good in relation to our peers, what our numbers tell us in terms of demand, particularly the types of demand and peaks in demand, whether we really understand whether the initiatives around same-day emergency care and making sure that the directory of services is properly reflected of what's required, and really into what the data tells us in order to really understand where are the areas that would really benefit from some particular focus. People talk about criteria-led discharge. Does the data support that? People talk about earlier discharges in the day. Does the data support that? And really to understand, properly know what the data is telling us in order to regroup and refocus our efforts. Because, of course, you could take the position, which we don't, but you could, that we're short of beds, and when the beds are open, that will be fine. We can't take that position without a proper evidence base to understand what the data tells us. We could say, of course, when the new ED department opens in February, that will solve everything. We know that there isn't the evidence at this point in time to tell us that. So we really need to get under the skin of that. And I think, David, once we've done that, it would be good to bring that back for a real deep dive conversation, so we all are on the same page in relation to that. That's the next steps.
Yeah. It would be good if we could do that at the July board. Okay, let's move on. Julie Moore.
Matthew, thank you. In terms of what you've just talked about with the data, will that data include a detailed audit of every patient coming through the front door to make sure that indeed the ED is the most appropriate place? And will it include a complete audit of patients about the most appropriate day and place for them to have gone to? Because we don't know that at the moment. I've not seen any data that talks about that.
Talked about that previously, haven't we? Actually, following a number of patients, we have had some really helpful support from the regional urgent care team, where they have looked at the appropriateness of patients being brought in, and whether, if the directory of services had been better utilised, those patients could have gone to an alternative setting. So we do have some evidence there, but we need to get under the skin of that a bit more. We of course have the Health Watch report, which interviewed patients and asked them specifically why they'd come to ED. And we know that there's some general practice access issues that need to be explored as well, which are being discussed with our primary care leaders. So we do have elements of data, Julie, but I think putting it all together and providing a proper analysis is, I think, what I'm articulating, really, to really understand whether the right patients are coming in, whether they're being seen in the right areas, whether alternative pathways are being better utilised. The data, such as we have, needs to be triangulated properly with all that in the way that you're describing.
When you say the most appropriate place, is that the most appropriate place of those that currently exist, or the most appropriate place if we were reinventing the system? So
yeah, I mean, certainly the regional team's analysis was that it also included, for example, if we had an urgent treatment centre, and that is something that is being considered, which of course we don't. We have a primary care unit, which is only GP, if you like, GP led. That would provide perhaps a further alternative pathway for a number of patients that are currently sitting in minors and essentially not probably in the right place. Of course, we haven't got the space in our current configuration to do that, but one of the considerations that Dave Raven and the team are looking at is whether in the new build there might be the opportunity to do that in a co-located space nearby, but that's still in early discussion, Julie. But yes, it's both. It's what's currently available, but what could be available if there was a different approach taken.
Anita.
Thanks, Chair. I mean, Matthew, I'm really pleased to hear that about this focus on data. I think that's exactly what's missing, and I think actually understanding what the numbers are telling us and what are the driving, what's the root cause of some of this stuff will be really helpful. In terms of the data, however, a plea which I would make, I think that anecdotally there is a sense that the performance of acute providers who are only acute providers, as opposed to those that also have some community beds, that they can sometimes manage their front door a little bit better or a little bit differently. I'm very conscious, and it's a plea really for the IPR going forward. It would be really helpful for us, I think, to understand our performance, given that we are an acute only provider. It would be really interesting for things like that to have a comparison against trusts that are in a similar boat to us, because I think if that is true, that it is that those that have community beds are a bit better are more able to manage their front door, then it may be that we're not getting a fair view of how well we're doing in the circumstances that we are.
Yeah, I think that's a really good point, Anita. And of course, in our integrated performance report, we do have the benchmarking data that compares where we are against all acute sites with EDs. It doesn't differentiate between those trusts that have integrated community services and those that don't. So we'll explore whether we can get that information to see how that compares as well. So thanks for the suggestion.
Christine.
Yeah, it was just to Julie's point really about services that are not available, that might avoid patients being conveyed or conveying themselves to RED. So we do know that there is a good evidence base for services working elsewhere in the country that we don't actually have available in Worcestershire, whether that's integrated frailty services, doc in a box services, outreach type services. We know that we have an issue with hospice at home, end of life care services being provided. So and we also know that the two biggest categories of patients who attend that turn out not to need treatment in the department are chest pain and falls, and are there examples of services available elsewhere in the country that could manage them without them needing to attend? So yes, we'd definitely be looking at that and learning from others.
Thanks for that. Any other points on the Chief Executive's report? Any other points? No? Okay, thanks very much. So I look forward to a deeper conversation around all of this at the July, around the urgent emergency care, but particularly the ambulance handover issues at the July board meeting. Thank you. Okay, let's move on then to communications and engagement. Richard.
Yes, thanks, Chair. Morning, colleagues. This is the quarterly update on communications and engagement. I'll take the report as read. I guess in terms of themes, what I've tried to do for this quarter's report is to reflect how we are focusing our efforts to support some of the key immediate and longer term issues that we're all working on, whether that's reactive and proactive comms around urgent and emergency care, or starting to build comms activities to support the rollout of the forward improvement system and the EPR. The continuing demands that are being placed on us by responding to the COVID pandemic. And although things are now easing, I think there'll be a period where we have to manage what I might call transitional comms. So for instance, managing the messages around the new changes to mask wearing, easing of visiting restrictions, and the like. So that will continue to occupy some time. But the good news is that those things are moving in the right direction, and colleagues will see mention of the Peony Room opening. That was the first time since the pandemic started that we were able to bring some local media on site to cover a good news story that wasn't COVID related. So that was very positive. And then I have also tried to reflect given the outstanding action from the last report, some of the things that we have done recently, to more diverse audiences internally and externally. Early days, to be sure, but I think some of the things that we've done have been positively received, and certainly working with our staff engagement networks and at place level, I think there is potential for us to make some progress on that important area over the coming months. The launch of the Staff Recognition Awards, and I'm delighted to say that since we launched on the 23rd of May, we've already received more than 200 nominations internally and externally, which is very, very positive. And our charity team have also had some significant early success in securing some sponsorships. So things are moving in the right direction on that. And then finally, given that the decision will be announced tonight, just to draw attention to Jazz Cartwright's shortlisting in the National BAME Health and Care Awards for her work as our inaugural network chair. So fingers crossed for Jazz this evening.
Thanks, Richard.
Thanks, Chair. I'll leave it there and happy to take any questions.
Thank you. Any questions? Comments? Simon?
Thanks, Richard. Did we go for a green award, by the way, or any green awards for our environmental work? Or
We've got a number of categories that would be amenable to environmental initiatives, Simon, including the ones aligned to the strategic objectives, the obvious one being best use of resources. There isn't a green specific one this year. No, there isn't a specific green one, but there are categories that would lend themselves to green awards.
Might be one for next year, because I think, as we've discussed in different fora before, it seems to be something that staff themselves are very enthusiastic about. And congratulations on the new app, by the way. It's great. Really works well.
Thank you very much. It was a longer time coming than I might have wished, and to borrow a phrase from the chairman, we did turn it into a bit of an industry, but it's nice to have it out in the public domain now.
Good. Any other questions? We've got the leadership conference coming up. Richard, do you want to say anything about that?
Week today, Chair. Hopefully everybody received their invitations yesterday, so we look forward to welcoming you to Wharton Park Golf and Country Club for some hopefully lively and engaging discussions around our plans, and then some exposure to the forward improvement system. I hope it will be a challenging, stimulating and uplifting day. Nice to be able to get together in person, and again I think that's one of the things that we would look to do as we come out of the pandemic and people can start getting together, not just big events, but to go back to some of the face-to-face briefing sessions and other live communications that we used to do to supplement what we do through electronic channels. But I think Thursday I hope will be the start of what will be a series of regular events for our senior leaders, to start really getting them involved in discussions around how we move forward on the big strategic projects, as well as the kind of things that we've touched on earlier around reinforcing the messages around building a compassionate and inclusive culture, and we're certainly trying to weave that into messages around the forward improvement system, as well as the work that we're doing with the staff engagement network. So it's just the power of those conversations face to face, and getting colleagues together, some of whom may never have been in the same room if they joined during the pandemic. So fingers crossed out we'll be reflecting positively on it at next board, Chair.
Thanks. What sort of turnout do you think we're going to have?
Somewhere between 100 and 120.
Right, very good. Excellent, very good. Look forward to that. Any other questions about the report? Thanks, Richard. Thanks for the work that you and your team do. Thanks for getting the ball in the back of the net in relation to the app. And I thought I'd bring football into it somewhere, just in case anybody wants to talk about football. Okay, thanks very much for that. We take the report for assurance. Thank you.
Thanks, Chair.
Let's then move on to the quality account. Chief Nursing Officer.
Thank you, Chair. So, as everybody realises, as I'm sure now, the Department of Health and Social Care requires providers to submit the final quality account to the Secretary of State by the 30th of June. Pulling together the quality account is no mean feat. And I want to personally thank Jackie, my deputy, Alan Bailey, the Associate Director of Governance and the Quality Hub, for their efforts in ensuring that we've got the data to go into this quality account, which again takes a good deal of effort to get this into the robust state it needs to be in to be delivered to the Secretary of State. It is here for approval, and it has an assurance level of 6. It's previously been received at TME and QGC. The data has now been finalised, so the quality count that's in your bundle isn't the one that has got the final data, but I know that Rebecca has sent that under a separate email, so that has now got the final data in for the submission once it's been approved here. Obviously, it discusses the quality priorities for 21-22, and they are listed on pages 13 to 21 of the account and 41 to 49 of your bundle. The descriptions of the priorities and whether we met them or not are in all of that particular pages. 23, and they are listed in pages 24 to 33 of the quality count and 52 to 61 in your bundle. And this has been formulated through the ongoing engagement with our stakeholders, and also it links to the quality plan and also to our annual priorities. Bearing in mind that this has been through TME and QGC, I am just looking for approval here, but I am willing to take questions on this.
Thank you, Paula. Anita.
Yeah, thanks, Chair. So, Paula, thank you. I mean, I can only imagine what a mammoth task this has been, pulling this together. Just a couple of points. First one is just an admin one for Rebecca. This has also gone through audit and assurance, and that's not listed on the front page. I don't know if you wanted to do that, but we have also signed it off. Having said that, there was just one thing when I was looking at this again, and particularly about the 22-23 priorities. I wondered, in the section about a positive experience for patients and their carers, I wondered whether our implementation of #CallMe should be in that section. Given that it is something that could absolutely have an effect on patient experience, and something that has got quite a lot of profile, I wondered if that was something that should be listed specifically. Thanks.
Thank you, Anita. I'll take that under consideration, yes.
Thanks. Simon?
Just to draw colleagues' attention on page 40 to the fact that Kidderminster Treatment Centre is rated as good.
Yes.
It's always good to see that.
Yes. Thank you, Simon.
Thanks. Any other questions on it? So, Paula, when you look at it, so if you gave me the financial accounts of the organisation, the Chief Finance Officer would tell me whether they were in a decent state or not, how proud they were of them or not. When you look at the totality of the picture that is described in this quality account, what do you think it tells us about the organisation as a whole?
I think it shows that we should be proud of what we've achieved. I think we've still got areas that we still need to prove, and that is demonstrated in where we didn't meet our priorities. But yes, I think we stand in good stead from a quality and state safety perspective, and I think that's demonstrated in going forward about what we still need to do.
Thanks. Julie?
I'd congratulate the team on producing something vaguely readable, because it's such a formulaic thing that comes out from the centre. And I mean, it was very helpful that one year I remember them giving us guidance of 111 pages telling us to keep it short.
Yes.
So I remember having readable, good reports being turned into almost incomprehensible stuff by the demands of the centre to put it into that. So I think the team have done a good job of making this as intelligible as it is, actually. I think we have to look at other indicators as well to look at how well we know our organisation is doing or not. It shows good progress, but I think all credit for doing silk purse sow's ear stuff.
Thank you very much.
And can I thank Julie for that vote of confidence in my stewardship of the centre. When we did actually I think send out a 119-page set of guidance to make it.
Saying to keep it short, yeah.
Yeah. Thank you. I remember it well. Thank you for that vote of confidence. Okay. Well, the first thing I would say is it is readable. That's not a fake praise and all that. I think that it is a mammoth undertaking to bring all this together, but it is quite a valuable resource. There's a lot of interesting stuff in here that we can use, whether Richard can use over periods in terms of comms, whether we can use in terms of sort of promoting our organisation and what we do in a more holistic way, rather than responding to the specifics that people often operate to us. So well done, Paula and the team, for bringing it all together. And I'll take from all that we approve the quality accounts.
Thank you.
Thank you.
Thank you very much.
Thanks, Paula. Thanks very much. Annual plan priorities. Joe.
Thank you, Chair. Good morning, everyone. So I'll take that the paper is read this morning. It has got a level 5 assurance and has been through both finance and performance and quality subcommittees where there were minor comments. Just to follow up, the plan was submitted on the 28th of April, and actually what we have here is we're translating the plan into our priorities for the year, the detail of which is shown in the reading room. We've translated those priorities into 4 key areas, which are outlined on page 3, under quality, improving access, healthier lives, and delivering value. And particularly under the quality one, as well as the good discussion we've just had around delivering care that is safe through our refreshed quality and safety strategy, we're also actually got a lot of exciting developments that will come to fruition this year, particularly around our capital projects with the UEC, the ASR, and our investment in the digital technology. And I think sometimes we don't always acknowledge and celebrate those facts. I just wanted to draw attention to that, as well as some of the activity things that clearly we need to deliver to help reduce the backlog for patients. So I don't propose to go through any more of the detail, Chair, but I just wanted to note for Public Board that we did receive notification, as did all ICSs, that all the 22-23 plans do need to be resubmitted for the 20th of June, and we're actively supporting the ICS on that, which we have a paper in the private board to discuss in more detail. Thank you.
Thanks. Any questions? Colin.
Thanks, Chair. It's referenced later in the assurance report from Finance and Performance, but I thought I'd mention it now that I think I totally support this statement of priorities. That the challenge for us as an organisation, particularly as a board, will be developing the set of matrices and key performance indicators that enable us to track progress. And I know work is ongoing on this, but I think it is an important issue that we move from analysis through to ensuring we implement.
Joe, do you want to say something about that?
Well, just to say, yes, you're right. We did rehearse this at F&P, didn't we? And we agreed we'd bring something back next month, and we were discussing this yesterday as execs as well. So we have got some further work we've been looking at from the Carter report and bringing all that information together. And so we will be doing that to bring it back through Finance and Performance Committee next month.
Thanks, Tina.
A minor point, but top of page 4 is a typo. It says adjust. It should be a just learning culture.
Yes, good point.
Thank you, Tina.
Okay, so is it the idea that we'll put the priorities with some measures plus how plus the numbers together in something that I would recognise as being a plan? Is that what's going to happen? Or am I old-fashioned? Matthew?
Yeah, I mean, thanks, Chair, and I think Joe's articulated that all of that quite well. What we now need to do is to translate this into something that's digestible for our staff, firstly, patients, and the wider public, which sets out very explicitly what our priorities are, how we're going to measure them, how that's going to be reviewed. We're looking at making sure that we've got that set of high-level metrics that tell us how we're doing against some of the big ticket issues. We want to make sure that then we don't have too much detail in the integrated performance report, so we're in the process of then there will be regular updates to the subcommittees that are particularly focused on oversight of some of the key objectives, and a regular update here, Chair. So, but I think the next step of all of this now is the communications team putting into plain English the exact priorities that we're setting out. So, long answer to your question, the answer is yes.
Okay, thanks. Very good. I mean, I welcome this. I think it's, straightforward and clear and all the rest of it. I'm going to slightly irritate you now by, I think if it could have been better connected to the pyramid than it is. That sort of, and I can see the irritation over this way, but I just think it would have looked better if we could have just thought about that, to constantly have that in front of us. But nevertheless, the substance of it is very good. And of course, now we've got, with the forward improvement programme, we've got the answer to the how, or the beginnings of the answer to the how in all of this, which I think is being voted for. Good. So, can we approve the annual priorities? We can, and we'll have a further conversation about risks in the private section of the board. Thank you very much. Good. Ockenden final report and gap analysis. Justine, are you there?
I am. Good morning.
Would you like, Justine, before you start, would you, at the last board meeting, I think, or a board meeting, we had a discussion about all of this kind of stuff and continuity of care and all of that. And I know that you were going to go off with some of my colleagues to talk to the staff about it all. I just wondered if you, in this conversation, you might want to talk to us about how that went and what you feel about it.
I will do. So if we just deal with the gap analysis and obviously the actions that we've already taken, and I'll cover the continuity of care actions in that part. So as we all know, the final Ockenden report was published on the 30th of March. Within that report, there are 105 essential actions. And within this report, you'll see that we benchmarked ourselves against those. Summary of the RAG rating that we completed was that we've got 57 where we would say we were green. This is really based on that we could put our hands on the evidence immediately and put it into the folders ready for submission if it was requested. So a high level of assurance that those are green. Amber, we've got 40 of the essential actions there and 8 where we think there's some considerable work still to do. The action plan is in process now, and that will be available in July. Some of the improvements that are needed are in areas like MDT training, our HDU training, providing more time for our clinical colleagues to deliver the governance agenda. Some of the areas where we scored particularly well, the finance of the maternity workforce, preterm care, neonatal care, bereavement care, and how we support our families. So some really good points there. The actions that we focused on after the report was first published were around continuity of care, as you've already mentioned, Chair, and following the publication of the report, we went through a process of discussion around options appraisals for whether we should continue or discontinue continuity of carer. Obviously, after that piece of work was completed, we agreed that the best thing to do would be to continue with our current teams, the 6 teams that we have, and we went back to our teams to share that information with the teams. I think it's fair to say that some of the team, all of the team members are very happy that they're going to be able to continue to provide the care in that way. I think it's also fair to say that some of our inpatient colleagues who don't work in that model really do support the model, but because they're under tremendous pressure at the moment, because that's where the majority of our vacancies are sitting, they did believe, until they saw some of the information, that the suspension of continuity may improve their staffing levels, and did feel that there was almost some hope that there was some additional support. That it had we made a decision to suspend, that wouldn't have been the case. So we're trying to support the teams now in focusing on things that they can help improve recruitment and retention, managing sickness more robustly, and trying to support staff to stay in the workplace. So a mixed response, I think it would be fair to say.
Okay. Okay. Any Anita?
Thank you, Chair. Justine, thank you for the paper, and this is helpful. Could you remind us, do we have an official timeline by which we have to have met all of the criteria? And can you give us some assurance that that we are on track to do that? Or do you foresee any issues with meeting that deadline?
So at the moment, we haven't had the same response or guidance that we had from our regional colleagues after the delivery of the first report. So at the moment, there's no clear timeline or expectation. Most services have just started to get on with starting an action plan and completing that in readiness for that ask. That's why we started creating the evidence folder straight away. So have quite high assurance that where we've scored ourselves green, we have that evidence in folders ready. We've been told that we're not going to go through the same process that we went through with the first report in terms of submitting evidence into a portal at periodic times. So we still wait to what they call insight visits, and we had one a fortnight ago. That went very well, and the purpose of that is for us to be able to demonstrate that we've implemented the recommendations from Ockenden, and I think that is going to be the approach going forward. It was a good meeting, and we told them where we knew we had issues. They agreed with us, and they also acknowledged that we had actions in place to address those issues as well. So no surprises, which is always nice, but we wait the final report.
Simon.
For the report, it's been very helpful. I know that we as a board will be getting quarterly updates, I think. Is there a committee that's looking at this on a monthly basis as the action plan is rolled out to oversee the implementation? And you may not be able to answer this one at this stage, Justine, but I know we've sort of got 8 reds and 40 ambers. Is there an expectation that those reds will turn to amber and the ambers will turn to green, or is there any risk that you might have some of the ambers slipping into red? So are there any particularly concerning you at the moment?
So just to answer around the RAG rating, we would expect everything to improve. Some of it's based on funding, and we have that funding now, and it's just about getting on and recruiting people into certain roles. Once they're in the roles, some of these are processes that we have in place. Some of the ambers, we have processes in place, but do we have good recent audits of those processes? Maybe not. So we've had to score ourselves as amber, but we have recruited a new audit and guideline midwife who will oversee all of those audits, so we'll be able to catch up with those when we've got the people in post, so they'll automatically turn to green when that happens. So I don't anticipate that we'll reduce our assurance level. It'll just continue to improve. In terms of monthly, we have a monthly, what we call a compliance and assurance meeting that's starting next week, and all of the gap analysis and action plans that we have for a variety of things will be monitored through that meeting within the directorates. I think at the last TME meeting, Matthew agreed that we would report 6 monthly. If we would like to change that, I'll take your advice today.
I thought I read in the report that it was a quarterly to board, but there isn't a subcommittee of the board that'll be keeping an eye on this on a monthly basis at this stage.
I don't know, Paul, whether that was a nod to agree that there wouldn't be, or a nod to say that there would be.
Yes, we'll take this through QGC as the subcommittee of the board to monitor it for board's sake.
Okay. Okay, Christine.
Yeah, you will all know that actually within the Ockenden report there are some implications for organisations outside of maternity services. So particularly looking at the way that we undertake serious incident investigations, how we engage families and the public in those, and how we link information from incidents and complaints and triangulate those together. One of our medical directors for patient safety and quality improvement has gone through the Ockenden report with that in mind, as has our associate director for governance, safety and risk, and we will be looking through serious incident review and learning group on any actions for the wider organisation that we need to take as a result of this report as well. So I think learning is not confined just to maternity, it's for the wider organisation as well.
Okay, in which case it seems to me that when we do the quarterly reports to the board, we should include that sort of work as well, so we get a holistic position. That's good. Any other points? Just one issue. In another place, I won't mention the name of this other place, but we saw a report yesterday which set out a timetable for full staffing, right? A timetable to getting to a place where there would be no vacancies for midwives. And there was a plan to do it using overseas midwives and all sorts of other things. I just wonder, have we got the equivalent of that here? Is there a point, is there a kind of moment where we think, given all the plans we've done and all the things that we'll be in a position where we get full employment, or whatever the equivalent of it is?
So based on the historic data that we've got in terms of turnover over the last 2 years, if we're able to recruit at the same level that we have done over the last 12 months, we should have no vacancies by February 2023. That is not using any overseas midwives, that is just local recruitment of our own students, and our progress with continuity of care is predicated on us meeting that milestone in February 2023.
Have you seen the report from the other place? It's just that, not without, please don't minute this or anything, but their final position was March 2023. So I'd assume then you'd seen it and decided you were going to beat it by a month, but that's not the case. Okay.
Just the reason we're February is we're quite lucky locally. We have 2 cohorts of students, one that qualify in September and one that qualify in February. So that's why it's February 2023. If we recruit incredibly well in September, we may be very close to that, but I cannot predict what our turnover is going to be at the moment. So for complete confidence and assurance, I would rather say that our time would be February 2023.
That sounds to me like really good news, isn't it? Really good news. If we can do that, we'll get close to it. I think that's a fantastic position, and gives hope to people.
Yes, finally.
You know, that's the thing. That thing I think for our workforce in particular gives hope. Are we not considering overseas midwives?
Not at the moment because of the number of midwives that we can recruit locally, but we may need to consider that later. We're looking at supporting our workforce and strengthening our workforce in different ways. We've got no midwifery support workers at the national framework level at the moment, and so that's where our focus is.
Okay. Thank you very much. And we note what you've said there. Thank you very much for that. Let's move on then to Board Assurance Framework and Risk Appetite Statement.
Thank you, Chair. The latest Board Assurance Framework has been updated to reflect the position as we go into 22-23. It's been through various committees of the Trust Board to reconcile the position that's been proposed by the Executive. The changes are set out as within the report. I'd like to focus particularly this month on looking at our risk appetite statement. This is a really important document for the board in that it sets out the level of risk which it is willing to tolerate against various positions. So we've batched up on page 104 of the pack the various kind of key areas of our work, and we've mapped that back against our strategic objectives. This is where we use the assurance framework to help balance the level of risk which you are willing to either tolerate or to accept, and then that in itself then lends itself to the mitigations that you might need to put in place against those risks. So the risk appetite statement is the focus for this month. We've, in order to develop that and make it a bit more real, as I've said, we've tied it to the strategic objectives, but we've also put a target risk score because, you know, what does a low risk appetite actually mean? So we've tried to put some numbers in to help quantify that for you. I'm happy to take any questions on the statement if people have got any queries. It's based on GGI good practice and is consistent with what you can see across many NHS trusts. The overall position in terms of the risks themselves is there is a slightly downwards trend in terms of we've got 3 risks which have decreased slightly. However, the overall position is of an ongoing and high risk position. Thanks.
Thanks. Can we just, sorry, Tina.
Sorry, due to the timing of the People and Culture Committee, it hasn't included the updates from there. So we did discuss those related to People and Culture and felt that we shouldn't reduce the workforce number 9 down to 12. It should remain at 15. And that's because of the increase in staff turnover and our continued reliance on bank and agency and premium staffing costs. And the other one we reviewed was number 17, around the engagement of organisational change. And we felt because of the increased oversight of organisational change through the Chief Executive Team meeting, where we review the change each month, that should go down from a 16 to a 12. So that's the recommendations from.
Thank you, Tina. And actually really good evidence that the Board Assurance Framework is live. It talks back to the issues that we've got on our agenda at the moment, and it's all part of that reconciliation that we do offline, which we'll report back through the committees next month.
Yeah, it almost looks as if it was settled. That was it. It was very good, very good. Okay. Can we just talk a bit about the overall BAF and the first bit, and then get on to the risk appetite? Any questions about the general position in relation to the BAF? I'll refer to my BAF expert here, Colin. Are we happy with the progress here? Is it moving in the right direction? Is it?
Yes, Chair. As I've previously reported, the board is my view that we're in a good place with the BAF. It's been reviewed by auditors and so on, and we've had good feedback. I think that there's clear evidence that we're using it effectively. There are a couple of areas, as ever, that we could perhaps focus on to make it even more impactful. One of them, I think, is continuing to get assurance that it's embedded within all levels of senior leadership and management. And I think the other thing is making more use of the assurance ratings themselves. We seem to be in a position where we have an assurance rating and it sits for quite some time. It would be better, I think, if we could find mechanisms to using the assurance rating as a sort of tool for accountability, set ourselves a target to improve assurance ratings and then follow that up over time. I think we're getting there, but they're the areas where I would say that we can be a bit tighter perhaps.
Oh, thanks, Colin. I'll ask Rebecca to respond to that in a minute, but I think Christine's got a point she wants to make.
Yeah, it's just something I've been mulling over a bit this week, and then when I looked at the BAF prior to this meeting, so we've clearly got a big focus on urgent and emergency care and elective recovery at the moment, which Matthew talked about at the beginning. What happens in practice is when a board is very focused on that, and as an executive, whenever we're at sort of level 4 escalation, we do cancel other activities in order to deal with.
You've disappeared, Christine. You've become
There
mute.
we are. It's all right. I've cured myself now.
Right.
Because we cancel other stuff to deal with the urgent and the operational, which is of course the right thing to do, there is a risk that sometimes you lose other important activities regarding strategy, planning, and governance and quality type activities as well. And we haven't got a risk on the BAF around that the focus on the urgent and operational might impact on longer term strategy and planning. Unless it's at a lower rating and is not there.
Yeah, that's a really good point, actually. Matthew, do you want to say anything about that?
Yeah, I mean, I think that again is an important reflection, as you say, Chair, and I think perhaps in the next iteration we should get a discussion on how that's reflected if it isn't, and make sure it is, because it is a real thing, as we found out earlier this calendar year, the challenge of getting our annual plan into good shape and then completing the 3-year plan on time because of COVID wave 3, or wave 4 in fact. So I think it's a good point Christine makes, and I think we should I'll bring the exec team together under Rebecca's leadership to make that happen.
Thanks. Rebecca, anything on Colin's points?
In terms of Colin's point, yeah, within the detail in the reading room, we do have for each of the risks what the target is, where we think we're going to be at the next review point, and over what the timescale is. Absolutely accept the point though about it's following through on that. Have we just rolled it over for another quarter or another 3 months or so, and so we can see what those changes are. But we do have, in terms of the score, we do have that assurance rating for both target and prospective identified for each of those issues. The trick is then in how we then wrap that around in terms of the other assurances that we've got elsewhere in the organisation, and the assurance mapping exercise that we'll undertake will help us identify where that sits within the organisation. Also completely accept Christine's point, and happy to help support a session where we unpick and unpack what that risk might be.
Yeah, very good. Okay, can we just talk about risk appetite? Can I just understand the process that we've gone through to get to this point?
Yeah, so we originally had the risk categories and the risk appetite set as a narrative description. That's been long-standing within the trust. We've taken the opportunity to review just to make sure that the descriptions still adequately reflect what we think a high risk appetite might be. We've batched them back against the strategic objectives, and then the change that we've made is to add the target risk scores. And then in terms of review, it's gone through trust management, executive and various board committees. I've also undertaken a discussion with the Consortium Director for Internal Audit Services just to reconcile that this fits in respect of the approach that other organisations are taking. And also we've used then, given his strong support of that, we've then used this as the basis to start the discussion about how do we manage risk appetite across place, so that we can then use that with some of our system working. And again, they've taken this approach and have shared the work that we've done in developing this for place. They've also shared that in other places. So we've had a robust process to review.
my brain is not big enough to be able to take in place at the moment as I overlaid on this. So let's just, it seems it passes the sort of, does it seem reasonable test to me. I don't know what other people think about that. Yeah. Okay, I'm not going to. Okay, so in terms of the board assurance framework, the points that Colin made, plus the point that Christine made to reflect on and think about how we take that forward, but nevertheless to approve the board assurance framework and to approve the risk appetite statement. Are you happy with that? Yes, good. Thank you very much. Let's then move on to the integrated performance report. Vicky.
Thank you, David. Hi, everyone. So this is the integrated performance report for April 2022, so month 1. And just to be cognizant of colleagues' comments that we've gone through last month and this month in terms of how we're refining and developing this product, with an understanding that we'll bring the new IPR product through the subcommittee cycle in June and hopefully into the June. And also just really conscious of the amount of information that people are wishing to see in this IPR, and we've got to get to a point really from my perspective and my team's perspective that we've got some alignment and that we're also then not overwhelmed. So we'll all recall when this was first produced, this particular product, that we looked at it was great, and we know that our operating environment moves on and everything else, so we just really, I think, just need to be conscious about what we want to use IPR for, because otherwise it'll become everything to everybody and nothing to nobody. So I guess that's my plea, and probably my team's plea as well, before I launch into April, David, if I may. So you'll recognise the format. It went through our TME and it was approved in May, and it's been through the various subcommittees. In terms of high level key focus areas, we yet again have picked up the cancer standards, and there has been some good news in there. So we'll recall in March that we actually had the highest referral number for quite some time, whereas actually in April that's considerably dropped. And there's a really helpful graph, I think, that illustrates that over the last couple of years. I think it's page 120 in the pack. We've seen some continued improvements in breast services, and you recall late last year that they were really struggling, but actually they've achieved their standards for 2-week wait and also breast symptomatic. However, our 62-day number of patient waitings has actually increased. In terms of the benchmarking position for cancer, you will also see an improvement in that position against our peer group, which is the West Midlands peer group. And Anita, taking your point, I think it was a really main point from earlier, so thank you for that. And the team are already on it, you'll be pleased to know. And then just going back to our comments from earlier, as an executive team, we are completely focused on this, and we absolutely recognise that it's not where we want to be, and neither that for our patients or our staff. So we work incredibly hard. I'm really heartening to hear about the deep dive work, and I know Paul will probably talk about some work that he's already got underway with the BI team. So urgent and emergency care, obviously then the complicating factor around COVID. So April saw the highest number of COVID admissions for us. That's obviously started to drop off in May, which is good news. And those non-elective pressures, which are demonstrated through all of our metrics around non-elective. Though you will note, of course, that we actually saw a high number of attendances through our ED in April, in fact higher I think than the April 19 position as well. So yet again we're seeing that increased demand. Infection prevention and control, which I know Paula will bring us up to speed on if any further detail is required, and then fractured neck FEMA as well, which we've talked about at this committee, and we also have talked about in depth at Quality Governance Committee. So the paper's here for approval, to be assured, Chair, not approval, and there we go. Thank you very much.
Thanks very much for that, Vicky. Any questions or comments? Wakar.
Yeah, thank you, Chair. Just on the urgent emergency care, the number of people, 1,388 patients were still on our wards 24 hours after becoming medically fit. How does that measure against perhaps the aspirational targets that we may have? and what are we doing to improve this?
Okay, who's going to respond to that?
Me?
Paul?
Yep. Hello. So in terms of the number of patients medically fit, they've been running across the trust. The number has increased. It was running around about late 40s per day, and at the moment has been running around late 50s, early 60s. And the majority of those patients that are medically fit but don't go on the day are pathway patients. There are some patients where I have to say we have declared them as medically fit, and they're then being identified as not gone, and the following morning when we follow it up we're actually undoing that and saying they're not medically fit. So there are probably, if we say that there's 60 patients medically fit for discharge, 5 or 6 each day switch back to being unfit. We've got the incident room and the discharge cell now functioning. I think we've got Paula, Mary Gay and myself were having a discussion this morning. We think we've got more to do on the incident cell to make that more effective, and we've talked about how to do that, but that is where the focus is set on the medically fit for discharge, so that they are picked up in the discharge cell in the morning, and then if we haven't got a on the day time for discharge, they will then be escalated to the incident cell to deal with the issue. But I have to say that the biggest area has actually been pathway 2, which is patients requiring a ongoing community hospital bed. By and large, we have seen significant improvements in pathway 1, with the majority of patients now going on the day. Not all, but the majority, and the objective, to be clear, is all. But having gone through this in more detail with colleagues in the Health and Care Trust, that they're identifying that a lot of at any one time 20 to 30 patients in the community beds are actually waiting pathway 1 discharge. So although we've improved on the day pathway 1 discharge from acute beds, it may well have knocked on to the community beds, causing delays there, which is then causing delays for our patients. But so to be absolutely clear and specific, Wakar, to your question, it's is it high? It's higher than we want, but it's not disproportionately higher compared to the region. We're in about the middle of the pack for delayed discharges. We're not out of kilter, and it's the discharge cell which is now running well and has been for a few weeks, but the incident cell, so the escalation arrangements, which is where the focus is to drive that down further.
I mean, the reality is, if we're looking forward to winter, the best way of increasing capacity for the system is to get those numbers right down. That is the easiest, quickest, and most logical way to do it. And so it's really important going forward. Anita, do you want to ask a question about urgent emergency care? Anita?
Sorry, Chair. No, I had a couple of other comments. If you want to carry on this topic.
Yeah, just finish anything on urgent emergency care before we go on. There may not be anything, but anything else. So Paul, we're in the middle of the pack for discharges. Our average length of stay is broadly in the pack as well, but we're completely out of the pack in relation to ambulance handovers. So why is that then?
Well, I think it goes back to what Matthew was saying at the beginning of the meeting as part of his report. I mean, we have to acknowledge there is an issue. I accept what Matthew said, but there is an issue about capacity on the Worcester site in particular. And I think everyone who's kind of come in and done reports externally and ourselves have indicated that somewhat eventually get the white space on board. Will it be clear as to whether that's the case or not, because that will provide 29 additional beds. But what our focus is on is, well, are we addressing the right thing? So we've identified that there are two, if you like, two areas that are in some ways the most important to address. One is ambulance handover delays, and the second is to seek to reduce and ultimately remove any patients staying in ED beyond 12 hours. Those are the two big ones, and that's not 12 hours from a decision to admit, that's 12 hours maximum in the department. So the work that we're doing at the moment is trying to identify what would have the biggest impact. So looking at the number of patients who wait 12 hours in the department and the ambulance handovers, the analysis work we're doing, and we should finish by the end of next week, is if we target knocking a day off length of stay, what would that do to those two, if you like, quality standards? Or if we achieved a 40% level of discharges by midday or 60 by 2 o'clock, what would that achieve? Or what's the absolute discharge numbers? So that we know that if we did X, Y, or Z, that would have the biggest impact on those two. Because the challenge Matthew has given us is, how do you know what you're doing at the moment will actually have the biggest impact on reducing time in ED and reducing time on ambulances? We have done the first piece of work, which we completed this morning, which has looked at the number of general and acute admissions and discharges we have a day, and at midnight the number of patients who are in our ED who have been declared as needing to be admitted but are still in the ED, to give us a first cut on, okay, how big's the problem. And that's clearly showing that on a kind of rolling 7-day basis, and we've gone back over 92 days, that on a rolling 7-day basis, on average, at Worcester, there are 4 less discharges a day than admissions, and then on top of that, on average, there's between 17 and 20 patients in our ED at midnight waiting to be admitted. So what that tells you is, if that's running on a rolling 7-day basis, we're sitting there with about 24 patients at any one time with a gap, which may or may not go back also to that point about, are we short of beds on that site? The position at the Alex is much better, but is still a deficit on average. On a 7-day rolling day average, the negative is about 2, so 2 less discharges than admissions, and on average about 4 patients at midnight in ED who have been declared needing to be admitted, but there's no bed for them. So the gap is, somewhere around about, let's say, 25, 26 on Worcester and about 6 at the Alex. So, and we've gone through all that. So what we're now doing is saying, okay, then we've clearly demonstrated we've got a gap. We've got that overcrowded ED department. We've got a mismatch. That is clearly leading to people staying longer in ED, and that's having an impact on 1-hour ambulance delays. or well, people being on the back of an ambulance when they should be in the department, what are the 2 or 3 key areas that we should put all our effort in to seek to deliver that impact on time in departments and time on an ambulance, and then that's where we'll focus our efforts for the next few weeks. And as I said, we'll complete all that work by a week tomorrow.
Okay, thanks, Paul. We'll have the opportunity at the next board meeting to go into that in detail. Wakar, is your question about urgent emergency care?
It is, Chair. I just had a point with the urgent emergency care services were rated inadequate for Worcestershire Royal and Alexandra in 3 areas in 2020 by CQC. So my question is, based on the stats that we see, the data, can we be assured that we are on a trajectory of positive change that would lead to a good rating?
Yeah, if we get ourselves in a position that we address this imbalance, we ensure that when people need to be admitted, they are admitted in a timely way, and that we do not have patients in the department beyond 12 hours, and that has the subsequent impact on ambulance handovers, that would move us, given on the CQC report, there are some issues still around staff and supporting staff and violence and aggression, but that would head us in a trajectory for good in both departments.
Okay, thanks. Let's then move. We'll have the opportunity to talk about this more at the next meeting. But Anita, and thanks for all the efforts people are putting in, by the way. I know that there's a lot of senior, well, as Christine indicated earlier, there's a lot of senior activity around all of this, and genuinely thanks for that, because I know it's on an hour by hour, month, day, and minute by minute basis that people are engaged in this process. Anita.
Yeah, thanks, Chair. I had a couple of comments / questions. So my question is in another section of the report, and it's about theatres and theatre utilisation. And there was and I think it led me to think that I don't actually understand how that is calculated at this trust, because there's a statement in there saying that there's lost utilisation of 25% because of late starts and early finishes, which seems a remarkable statistic if that's true. So it'd be helpful if I could understand that a little bit, and does that actually mean what it seems to mean? But my second thing was really just a comment, and I really wanted to get to this before we got into the nitty-gritty. I mean, clearly there's and this conversation we've just had about urgent emergency care is a really important one. What I was really struck by, however, when you look at the report in its entirety, was how many areas we're actually doing pretty well, how many areas in which we're actually improving our performance and our benchmarking against our peers, and not at all taking away from the sort of the areas in which we are having difficulties, and that discussion we've just had is absolutely a key one. But I do think we need to applaud the team for the areas in which progress is and progress against the pack is happening. So again, just wanted to say thank you to the team as well, because there are clearly some things that we are getting better at. Thanks.
Thanks, Anita. Who wants to take on the specific issue about theatre utilisation, stop-start?
So can I pick that up, Chair? So in terms of we're doing a kind of, instead of just playing through the divisions, what we're now doing is getting much more engagement, and I put my hand up, this is my fault, I should have done it earlier, with the clinical directors. So on theatres, we now have a fortnightly meeting which involves 3 of the divisional directors and directors of ops, and 1 of the divisional nurses, and 7 clinical directors covering the surgical specialties, theatres and anaesthetics. And what we've been doing, and so this is an answer to your question, Anita, what we've been doing is going through what the hell is going on in theatres. We had a closed 2 sessions where we agreed that we would throw everything on the table, what we thought was wrong, without it being a blame culture, but throw everything on the table, and if you don't throw it on the table, you're not allowed to speak afterwards. So we did that, and one of the things that's given us a really rich set of information to now use to drive forward improvements in theatres. And so that's the next step now. That's what we're doing and making changes. To answer your question, yes, what it says in the IPR is correct, but we're scoring an own goal. So one of the things that we do, because it was a national qualitative initiative, and I would say, given the Chair's earlier comment, a more recent national qualitative initiative, that you should bring patients in a staggered way on the day of operation. And then talking that through with the clinical directors, who are surgeons and anaesthetists who are actually in theatre, what they're saying is that has a massive impact on the start and finish time, because they're coming in and out to finalise the consent and pre-op for the patient. What I was always used to, and what they were saying was, if we've got 5 patients on the morning list, we bring all 5 in at 7:30, we do everything with them, we're in the theatre at 8:30, and we don't come out till we finish the 5 patients, rather than plodding in and out and in and out. So that has caused that approach that we've taken, which we're doing from a national qualitative initiative, has actually caused late starts and disruption during the list. And then the second issue that we've had in terms of early finishes are 2 things. One, we're listing the patients, and on the day of the procedure, all patients going into theatre are being LFT'd, and we're picking up that they're COVID patients. So we were going to do 4, one's come back positive, and we've only done 3, and that means the list has finished early. And secondly, and this is not a criticism, but it's just a comment, that if we feel there's a risk that the list might run over, there's been a tendency to cancel the last case, when perhaps the approach we should take is, these are the patients and the procedures that are going to be done on the list today. Like, how as a team of theatre nurses, recovery, scrub, surgeons and anaesthetists are we going to run this list to make sure all of those 4 patients are treated? So it's a bit conservative, bit of cancelled on the day, and a process that we put in place for good reasons that's had a really negative effect. And that's just those couple of that gives you some, if you like, some colour to the pure data, that and have the people in the room who are in the operating theatre, you then start to pick up why we're seeing those. And that means, we've now got a fantastic, if you like, set of experiences that we're now translating into changing the way we run the operating theatres. So I would hope when it comes to the end of Q2 in September, and you look at that figure, it will be a few %.
Thanks, Paul. Okay, any other points that people want to make on this? Can I just a couple of things really? Is the and I agree with Anita in terms of the overall progress. The things that stand out to me is the cancer 2-week wait, and we've had this debate about referrals going up and going down, and whether they're the right referrals and all the rest of it. But what are the prospects going forward? Is there an issue about capacity that we have, or what? What's the solution to all of that?
I think it's a mixture, Chair. There are some capacity issues. There's also some issues where we're doing things in sequence, where we could do them in parallel and therefore reduce the time taken. There are issues around appropriateness of referrals. As Vicky pointed out in the report, we saw a big increase in the last quarter of last year in referrals, but we saw no increase in the actual number of confirmed cancer cases, which, you know, is a clear indication that more people are being referred, but, you know, they do not have cancer. So there's a process issue, there's a capacity issue, and there's a referral issue, and there's also just around making sure that we make best use of the skilled staff that we've got. Not everyone needs to see a surgeon or a physician in the first point of contact. I'm pleased that we have been able to appoint Carl Elson as our new clinical director for cancer, and Carl will start on the 1st of July. For those who don't know of Carl, he's an experienced clinician who's a GP by background, so he's the first senior clinical appointment that we've made from outside the organisation. And he's going round at the moment in advance of starting, meeting with all the MDT leads to identify where the issues are for each tumour site. So that, again, a bit like what I've just explained in terms of theatre, Carl's doing the same on each of the tumour sites for cancer, so that we will be able then to make sure that instead of saying it's a capacity issue, well, it might be in colorectal, but it isn't in breast. So it's having a specific top 2 or 3 things. And it's both achieving, whilst we do want to achieve obviously the 2-week wait standard, our target is the 28-day faster diagnosis standard, and obviously the 62-day treatment standard. So at the moment it's a mixture, but we're getting into the specific of what are the causes in each tumour site.
Okay. I mean, it would be good to get Carl, when he's got his feet under the table, to come to the board and talk to us about what his cancer plan is. Because in a sense, the real issue here, and this is when I've had conversations with general practitioners on this, the real issue here is one of the reasons our cancer outcomes are so poor in the country as a whole is late diagnosis. And in a sense, I know people will say to us that GPs are referring them because it's the easiest way of getting a patient seen quickly, sort of thing. That has to be the focus. How do we get early diagnosis? How do we get that for our population? That's the best way in which we can take it forward. So we'll look forward to that, and hopefully we can schedule in Carl coming to talk to us about all of that. And then my final point was about, because we were doing so well here, weren't we? I remember myself, you know, that we were very poor, and then we moved the service to the Alex, and we got really good, and now we've moved the service back to Worcester, and we've got really poor. So what Christine's going to answer this question, I can see.
Yeah, again, Chair, it's multifactorial. So some of it is related to theatre capacity. We've had increased numbers of fractured neck of femur patients as patients who were deconditioned or became deconditioned during lockdown and isolated have come out and fallen over and fractured their necks of femur. So the numbers have increased. Our theatre capacity has not been sufficient always for the numbers of patients we've had in at any one time. In the last reporting period 48% of the patients who were delayed in getting to theatre, it was because they were medically unfit, which is reflecting a frailer population of patients that are coming in. But there's issues really at lots of points during the pathway. So I'm working with our new lead clinician for trauma, who is an ED consultant who's got a special interest in silver trauma, and the orthopaedic surgeons, and with my deputy to look at that pathway, to look at what the delays are at every point within it, but it is multifactorial.
Okay, and my assumption is QGC is all over this. Because follow this through. Okay, thank you very much. Very good. Any other points? Let's move on to the subcommittee reports. Starting on page 189, Finance and Performance Committee Assurance Report. Anybody want to say anything about this?
Yes, Chair. Richard asked me to cover, because he can't be with us. I think I've referenced the point that we talked quite a lot about already, that related to developing the measures to track performance of the implementation of the priorities.
Yeah.
Everything else I think is taken as read. Thank you.
Thank you. I think we've covered those. Okay, thank you very much. Let's move on to quality governance. Sue, are you there?
There's a bit of a microphone issue. We've already covered the quality account, which was our first escalation, and it's just for board to have eyesight of the ongoing head and neck review, which is also got oversight by the CQC, and was fully discussed, and we'll come back to you.
CQC, did you say?
I think I did say that, didn't I? Sorry, I get all my acronyms completely muddled. I do apologise.
No, so I just thought,
Our masters.
All right. Is this QGC or CQC?
The CQC is seeing it. Sorry, that's what I wrote down. Yeah.
Matthew, tell me about this.
Yeah, sorry. So I think the key point that I think Sue's relating to is obviously the CQC are always very keen to see outputs from any invited external review.
Right. Okay.
And of course, the board will remember that back in early 2019 we suspended the tertiary cancer surgery that we shouldn't really have been performing. We then had an invited by us external review that has taken some time to conclude. It was important it came through our governance processes prior to us then reporting formally to the CQC. So that's the point I think for the board to be aware of. Thanks.
My confusion. Sorry, Sue.
Well, no, it's my. I wasn't being very eloquent. It's an ongoing process, and it will come back to you.
Okay. Thanks very much for that. Let's move on then to people and culture.
I'll cover that, please, David, because Colin stood in for Juliet's short notice. So one of the things that we covered at the committee was quite a difficult staff story about individual who's been subject to sexual harassment. Did feel brave enough to raise that through the Freedom to Speak Up Guardian and got good support through that route, but felt quite isolated in the organisation. So definitely some lessons to be learnt around the support through line management and a revision of our HR policies and processes to make sure that they feel supported by the organisation as well. So we've agreed as a committee to receive an assurance report at the next meeting to make sure we've taken forward those lessons learnt and got an action plan in place to address those. The other main agenda item that we covered was our 3-year plan for people in culture, and so we took through quite a detailed plan, but there's further work to do around making sure we're clear on the outcomes of those, so what will look different by when, and so that's being taken forward back to the next committee meeting before coming here for approval in August, September. And then we also discussed in detail the Workforce Race Equality Standard report and where we've got room for improvement. And we have developed a 7-point plan to respond to that and some other quality, diversity and inclusion issues. And that plan's going to be presented to the Trust Management Executive this month and then go back to the committee for the following month. And we covered was the Academy update, where we've made some good progress in setting up the Academy, but you'll note quite a low assurance rating of 2. So again, we're focusing our next meeting on gaining further assurance on the progress of the launch of that Academy.
Yeah, thanks. Any questions on that, Matthew?
Yes, just sort of an associated comment. Obviously the workforce and people and culture element of our 3-year plan will need to be coming as part of the overall 3-year plan as opposed to separate to, just to clarify that point.
Simon?
Thanks, David, and thanks to Tina for raising the issue of the staff story, because that's what I was going to ask a question about, or questions about. Do we know how frequent these incidences are? Do we have sort of data on staff coming forward if they have been sexually assaulted? And I guess it's just that sense of, do colleagues feel safe enough and supported enough to speak up when this is happening? Because I guess I know it's not an isolated incident.
So we do record all of the casework coming forward. So Mel keeps a separate confidential log for all those concerns being raised through the Freedom to Speak Up guarding, because they're obviously a confidential route. We also keep a formal log centrally in HR of any cases raised through that route as well. It was it wasn't a sexual assault; it was sexual harassment. The staff story did expose where there were some issues in that area before that individuals had raised through line management but hadn't made its way either through the Freedom to Speak Up or to HR. So there's the compassionate, inclusive leadership piece, and also all the number of mechanisms and confidence people have to raise those concerns. And I think by telling these staff stories and learning from them, that's the way that we're going to improve our culture going forward.
Anita, then Matthew.
Yeah, just to comment. So, I mean, and particularly on, following on from the discussion about the staff story, which was very upsetting, and I'm aware of it from a Freedom to Speak Up perspective. I think what this really brings home even more strongly, if that were needed, is that we have got to get a lot better. My understanding is that actually the area of the trust in which this happened, that there are rumblings from other sources as well. And I think that I think Tina, you and I have got a discussion. I think it's next week or something about this. But I think this thing of using information from the networks, from Freedom to Speak Up, from staff surveys, RED, DES, etc. We've just got to come up with a heat map that says, in this particular part of the trust, there may be issues. For these particular types of staff, there may be issues, so that we can really focus, the resources we have to tackle the areas of the greatest challenge.
I mean, I think I know it's always difficult in these circumstances because of confidentiality, but it's really quite important that people like Matthew in his briefings to leaders talks about this kind of stuff and talks about that we're actually tackling it and dealing with it. I think it creates a better atmosphere for people to be able to raise things in the future. Matthew?
Yeah, thanks, Chair. That was exactly the point I was going to make. That one of the key things, and we know this from clinical incidents being raised as well as other health and safety incidents, if people feel that something is going to happen as a consequence, the evidence is that does promote reporting. So we have had a discussion, including things where we've dealt with fraud and other behaviours, how we make sure that is articulated and communicated into the organisation, Chair, in the way that you described, so that people can get the sense that something will happen as a consequence. But I think also Anita's points are absolutely right. How we help our local managers to use the data that is to their hand to spot when a problem is developing and have early intervention, I think is the crucial bit, and perhaps a key learning from this particular case that I know Tina and the team are working on. So thanks, Jack.
Okay, thanks. I mean, I know that from my, sorry, do you want to come back on that, Anita? No. Okay. Certainly in workforce terms, if you're not careful, and I know Tina's aware of this as I am, is that you end up with a list of stuff to do. But there are some things which seem to me more important, and the way I would describe them is they're sort of keys that unlock a whole load of other stuff. Because people don't live in compartments and work streams, they live in what they do. And I mean, if you look at a staff survey and you look at the kind of the issues for us around middle management and first line supervision, that's clearly a key that will unlock a whole load of other stuff. And if you want compassionate and inclusive leadership, you know, that's where it's going to make the difference with people like this. And now I'm going to draw a connection between your Red Trust Academy update to make, because I was really worried when I saw it. Because it seems to me, tell me if I'm wrong, I may have got completely, but the Trust Academy was going to be a big engine for creating that sort of leadership in the organisation, and it seems to be in, well, it's red, so it's 5 boots and all. Can you just tell me, am I right to be worried, or am I just getting the wrong end of the stick here, Tina?
We've been slower at setting up the academy than we would like, is the position. That's why it's rated a 2. We have been successful in setting up some of the faculties around the nursing and midwifery, and obviously the medical and the healthcare support worker faculties. But the cross-cutting themes like the leadership, Dave, we have got the leadership programs, but we haven't progressed as much as we would like in making sure that we've got the number of leaders that we need with the right skills, knowledge, etc. And that's what we've committed to as one of the priorities for this year. We're committed to making sure we've got 250 people through our design program by March of next year.
Okay.
So, but that's why it's rated red. But that's we've got further work to do. And what was the key reason for the rating was that the outputs of that one example I just provided, we haven't been clear enough on what's going to look different by when, and that's what we need to go back and work at further.
Yeah, I mean, we need obviously leadership cadre in the organisation which kind of embraces and understands what inclusive and compassionate leadership really is. But we also need a group that kind of understand what their part of delivering the strategy is, or delivering the annual plan. Everyone needs to understand what their part, and they're the issues, I think, that will unlock a whole load of other stuff. And is that primarily going to be driven by the description you had of the 250 people by the end of March?
Yes.
Right.
Yes.
Okay. Colin.
I just wanted to really reinforce the point you're making, Chair, because I had my initial learning experience on the forward improvement process recently, and one of the key things is staff will be encouraged to refer matters to their line managers, and it will fall to the line managers to help to implement and secure the improvement. And a key part of that is training and equipping our managers to do just that. And so it's not just the issues that we've talked about just now that we need to be sure are covered in our leadership training and development, but it's this whole suite of things that they will be required to do in a slightly different and hopefully better way. And I share your concern really with the development of the academy, and I look forward to getting the further report which shows the steps that are being taken to get this into in situation as quickly as we can.
Thanks. Okay, well, so that's correct. So no doubt the committee will keep this under close monitoring. Very good. Okay, thanks very much. They're all noted for assurance. The safest staffing report, Paula.
Thank you, Chair. So obviously this report is here for assurance. It has an assurance level of 5. I just wanted to draw out some really good points. Our HCA vacancy continues to reduce, which is brilliant news. Bearing in mind we have had some major gaps there. We have also got an interview panel and assessment centres throughout the summer and into the early stages of autumn, so that we can actually have a pool of HCAs, healthcare assistants, to pull on when we get natural attrition and turnover. And our bank usage has increased, which is what we wanted to see, because they're our substantive staff, and our agency usage did decrease in April. And our vacancy target for registered nurses has dropped to 5.74%. And those are the issues I wanted to draw out. I'll happily take any questions.
Thanks very much. Any comments? Okay, we've been asked to note some specific things. That the staffing adults, children in neonatal wards provide the safest staffing levels for the needs of patients being cared for throughout April have been achieved. Continued rise in patient acuity and dependency, and increase in staff sickness, and slow reduction of COVID positive patients. This has impacted upon the needs for temporary staffing. The vacancy for HCA have continued to reduce to 9.45%. Key area for targeting recruitment is the urgent care division. Targeting international nurse recruitment will support the urgent care position. There are 23 insignificant or minor issues reported, which is an increase in a month, and 2 moderate incidents of these increased within the division. Okay, can we take that paper for assurance? Okay, thank you very much. Midwifery.
Thank you. So, staffing report for midwifery for April. Previously, we've offered an assurance level of 4, but I'm pleased to say we offered an assurance level of 5 for April, and that's because we saw a reduction in sickness, a reduction in vacancies. We increased the time that we met the acuity, and there was a reduction in the frequency of red flag reporting. We needed to use our continuity and community staff to support the inpatient areas on 6 occasions, and you'll see within the report there were fewer staffing incidents reported, possibly because we've now got a well-used acuity tool where all the staffing issues are inputted into that tool, which informs this report. So I believe that that's why we're not using the data system to report those, which is acceptable. There were 6 medication incidents, none of which caused harm. So generally a better month in terms of midwifery staffing. What isn't in this report is any information around maternity support workers, and I'll include that going forward because they are a key focus for us for this year. We've now been able to finalise 2 job descriptions, one for a midwifery care assistant and one for a midwifery support worker, and 4 of our midwifery support workers have commenced their apprenticeship training. So that workforce is starting to be developed quite nicely now. We expect another 4 to 6 members of that team to go forward for their apprenticeship training within the next 6 months. Hopefully eventually to then have a workforce of about 20 and can provide additional skills and support to midwives, particularly in the postnatal and community setting. So that will really help with our workforce development. And I'll pause there for any questions.
Thanks very much. Any questions? Simon?
Thanks, Justine. Just on that penultimate paragraph on page 202 about safe staffing not being maintained on all shifts, and the implications of that and what we're doing about it. I know you sort of addressed it a little bit, and are there any early indications from May of how we've managed with safe staffing levels for those shifts?
Yeah, so the minimum safe staffing levels are obviously set on numbers, So we have to be clear that those numbers that we set were not always met. Sometimes we have to use professional judgment then of whether we go into escalation and whether the acuity requires us to do that. So it's very much you look at the two data points, the numbers of midwives that you have on duty, but also what is your acuity telling you that you need at the time. So I think although the minimum safe staffing levels were not always achieved, acuity was met, and from a professional judgment perspective, women were safe at that time. May is a similar picture to April. We had a very challenging June bank holiday. I hope that we can still provide assurance at level 5 in May, but as I say, the June bank holiday was particularly challenging, and we've also now started to see a slight increase in the number of midwives with COVID again, which we're just monitoring at the moment, and I'm hoping that will reduce again, but COVID certainly hasn't gone away, and we are still seeing challenges because of that.
Okay, thanks. So we can take that report for assurance, please. Thank you. Good.
Thank
you. Trust Management Executive for information. Any comments on that? No. Good. Okay. Any other business? There isn't any. Can I thank you for your attendance at this, and that's the end of the meeting in public. We'll now move on to the Trust Board meeting as a corporate trustee of Worcester Acute Hospital Charity. Apologies, I've got Richard. Declarations of interest, there are none. Minutes of the meeting of the 7th of April. Are they a reasonable reflection? Yes, thank you. Charitable funds report. Do you want to say anything, Colin?
I'd just highlight really, Chair, that we're beginning to move away from the impact of COVID a little bit. We're beginning to achieve some of the objectives we set ourselves. Of note was the fact that we've developed a relationship with DHL. So one of the key planks of our strategy is to have a really strong hold on the corporate part of the marketplace. And this is a first and an important development. Otherwise, I think we can take the rest of the report as noted.
Okay, any questions? No, thank you very much. We note that. Any other business? No? Okay, that's the end of the meetings in public. We'll meet again in private at 1 o'clock. Thank you very much for your attendance.
Mm.